you so much for the kind introduction, and it's really a pleasure to be here. I'm going to be presenting some sort of preliminary work, and so I'm very much looking forward to getting your feedback on it. I think I'm also going to be speaking to you from 6 miles away, but remotely. So hello from Roosevelt Island. Okay, great. So this is a talk about studying inequality and inequity in healthcare and public health. And so I'll just start by pointing out a couple basic facts. The first is that healthcare and public health remain profoundly inequitable, right? And COVID is maybe exhibit A of this, but there are myriad other examples as well. This point is well known to all of you, so I will not belabor it. You're probably also familiar with the fact that algorithmic approaches are no panacea to health inequity, and indeed have made the problem worse at times, right? And, a very high-profile example of this is a science paper from 2019, which basically showed that a widely used algorithm used to predict health risks exhibited racial bias in that Black patients with a given risk score were sicker than white patients with the same risk score. This bias occurred because the algorithm was trained to predict cost as a proxy for health, and Black patients who had unequal access to care in the data set the algorithm was trained on had less money spent on them than equivalently sick white patients, and so the algorithm internalized this bias due to the bad target label. But today I'm going to be pursuing a sort of more optimistic counterpoint, which is that algorithmic and data science approaches, though not by any means an automatic solution to inequity, can, if properly applied, shed light on it and potentially help us reduce it. And I'm going to, make this point. In general, my work sort of explores this idea through two pathways for sort of using machine learning to increase health equity. The first pathway relates to how can we sort of use machine learning approaches to make fairer and more efficient health decisions, basically to de-bias both human and algorithmic decision making. And I've explored this in a variety of contexts, some of which I'll be talking about today, from policing to medical testing to risk prediction. The second pathway by which we can use machine learning to increase health equity is by understanding the health of understudied populations, whether they be women or racial minorities, etc. And I've explored this in various contexts, from COVID to pain to menstrual cycles, etc. Today, I'm going to be telling you 3 stories along this theme. And the first is about policing, and it turns out it's related to medical testing. The second is about intimate partner violence, and the third is about using race and clinical algorithms and when we should do so. The last 2 pieces of work are very preliminary work, unpublished work, and so that's why I'm excited to present them and get your feedback. You may wonder, what do these stories actually have to do with each other? Did you just choose 3 stories that have nothing to do with each other? Yes, it turns out the common theme, the common methodological theme underlying all these stories is that they are about missing data, which is, as it turns out, something with profound connections to health inequity. The other thing about missing data is that it's very difficult to deal with, as I suspect many of you already know. It's a very difficult technical thing to think about and correct for, and so this is in some sense a problem which has grown to obsess me. And in the same way that you talk about things that obsess you to lots of people, irrespective of how interested in them they may be, that is what I am doing here. You can think of this as sort of a cry for help. So specifically, the first 2 stories have to do with missing data and its connections to understanding human bias. And the third story is about missing data and its connection to algorithmic bias. And hopefully these will naturally lead into each other. Okay, so let's start by talking about the first story, policing and medical testing. And there's just joint work with a number of excellent authors, and it's published over the years in sort of Nature Human Behavior, AI Stats, and so forth. So policing is not just a criminal justice issue, it's also a public health issue. It is a major leading cause of death for young men, particularly for young African American men. And today I'll be talking to you about police traffic stops. Why do we care about police traffic stops? Basically because tens of millions of Americans are stopped every year in this way by police. It's one of the most common ways we interact with them. And if you've sort of followed the news about high-profile acts of police violence, you will observe that not too rarely they begin in a traffic stop. And there's been concern, of course, that traffic stops may be racially discriminatory. To be clear what I mean about racial discrimination, this is when someone is treated more negatively on the basis of their race. So they're stopped by police because they are Black. They would not have been stopped had they been driving identically, but they've been white. Now, there is abundant prior evidence of potential racial biases of this form in police stops, and that evidence comes from many sources, right? It comes from, the lived experiences of minority drivers who frequently attest that this is something that occurs. It comes from social science evidence, in economics and sociology. It comes from statisticians. Nonetheless, it is quite hard to quantify racial bias in police stops on a national scale for reasons that I'll discuss, and that was, in fact, exactly the goal of this project. So why is this hard to do? The first challenge we confronted when we embarked on this is that there was no unified national data set tracking every stop made by the police. Rather, the way policing works in the United States is that every department tracks data in its own siloed idiosyncratic format, and there are hundreds or thousands of police departments across the United States, and so all of them have data stored separately in a different way. So we set about creating such a data set. And phase one of this was that we worked with our journalist colleagues who really did remarkable work to submit data requests to more than 100 police departments over the course of 5 years. This was really just a mammoth task on their part. And more broadly, if you ever have to get access to a lot of data, which is difficult to get access to, I highly recommend working with journalists. They are pretty remarkable. So then the data all comes pouring in, and as I suspect like this introduces a nightmarish data standardization task, right? The data all comes in different formats. It comes in floppy disks. It comes in Excel files. Like every bad possible way you could think of to store data, we receive data in that format, probably, right? So there is no shortcut here. This was thousands of hours of cleanup, tens of thousands of hours of tens of thousands of lines of code written by many people. I'm not going to tell you about that in detail, except to give you the good news, which is that task is now completed and all the data and code are available online. So you can just download it yourself if this is something you're interested in. And I should mention that a single analysis here really can only scratch the surface of what is possible with this data set. I think there's a lot of other work that could be done here. Our main analysis looks at tens of millions of stops, and we sort of limit to the agencies where you have the requisite data to even look at this question at all, this question of racial discrimination. So for example, if a department does not track race because we do not racially discriminate, so why would we even track that data? Whatever you might think of that argument, it nonetheless makes it quite hard, of course, to analyze racial discrimination. So in our analysis, we look at 3 questions. We look at whether the police discriminate in whom they stop in the first place. We look at whether they discriminate in whom they search after a stop. And finally, we look at the effect of policy changes on these racial disparities. Today, I'm only going to be talking to you about the second question, and you can find the answers to the other questions in the paper, but the reason I focus on the second question is because it turns out that the methods we'll develop are applicable to studying bias in many other decisions, including in medical testing decisions. So, are police searches discriminatory? A little bit of context on this. How do police searches work? When the police stop the driver, they're allowed to conduct a search, and the purpose of that search is to find contraband. So contraband here means things you're not supposed to be carrying, so like illegal drugs, weapons, etc. The purpose of a search is to find contraband. It cannot be to harass the driver or because the officer is bored or because they have to satisfy some quota or whatever. And given the purpose of the search, our definition of discrimination is, are minorities searched when they are less likely to be carrying contraband at a lower threshold of evidence? So in other words, if police are searching white drivers when they're only 90% likely to have contraband, but searching black drivers, when they're only 10% likely to have contraband, then, the fact that they're searching black drivers on the basis of less evidence when they're less likely to have contraband, that's discrimination under our definition. Importantly, this does not cover all forms of problematic police behavior. It says nothing, for example, about disparities in police use of force. And that's one of the reasons we've made the data available to allow other analyses of other ways in which the police may discriminate. Nonetheless, this is an important type of discrimination, and it's what we assess in our analysis. So what's the connection to missing data? This is a missing data problem. Why? Because we only observe search outcomes, whether the search found contraband, for the people the police historically searched, right? For the rest of the folks, we don't know whether they were carrying contraband or not because they were never searched. Which is to say, the outcome data is censored by human decision-making, by the officer's decision to conduct a search. And this is a challenging form of data censoring because people, are potentially biased. That's the whole point of our analysis. But they also potentially have access to unobservables, which are relevant to the outcome. For example, is is the driver acting nervous, might be both relevant to the outcome of whether the driver carries contraband, but also to the officer's decision to search them. And furthermore, it's probably not something that's written down in your police data. All of this means that the unsearched population may be very different. We cannot simply train a model on the population for whom we observe outcomes, the searched population, and assume that it generalizes. More broadly, this problem has been known by many names, but the one I'll use is selective labels. And as I'll discuss later, problems of this form appear in many other high-stakes domains where basically the outcome you care about has been censored by historical human decisions, including in medicine. So how do we test for discrimination in searches? The first simple test which has been proposed is look at the search rate. Look at how likely people of different groups are to be searched by the police. And when you do this, the disparities are immediate and striking. Minority drivers, Black and Hispanic drivers, are far more likely to be searched after a stop than are white drivers. But this on its own does not prove that the police are being discriminatory in the sense that they are applying lower search thresholds, right? It is possible that some groups are simply more likely to be carrying contraband when they're stopped. The purpose of a search is to find contraband, and so if some groups are more likely to carry it, the police may be more likely to search them simply in the course of normal police work, not necessarily due to applying different thresholds. So a second simple test which has been proposed responding to this shortcoming is don't look at how the rate of searches, look at the outcomes of those searches. Specifically, look at how likely searches are to find contraband. We call this the hit rate. And if the hit rates vary by race, this is sort of evidence of discrimination. What's the evidence? What's sort of the intuition for this? Well, imagine that searches of white drivers are finding contraband 90% of the time, but searches of Black drivers are finding contraband only 50% of the time. It suggests that the police are searching white drivers only if they're very, very likely to be carrying contraband, but searching Black drivers at lower thresholds of evidence, right? But sort of more randomly, that's why they're getting a lower hit rate when they do. So basically if hit rates are lower for minority drivers, then this is evidence of discrimination under the outcome test. And when we look at our data, that is in fact exactly what we see. We see that the hit rates for Black and Hispanic drivers are lower than for white drivers, suggesting discrimination under the outcome test. But it turns out that the outcome test too has a flaw, and this is known as inframarginality. And I'll illustrate this issue to you with a simple, purely hypothetical example. So these numbers are made up. This is just to sort of illustrate the statistical shortcoming. Imagine that there are two races of drivers. There are Black drivers and there are white drivers. And among each race group, there are two easily distinguishable groups, those who are highly likely to carry contraband and those who are quite unlikely. And these groups are easily distinguishable, like maybe one of them is wearing hats, right? Among the likely group, 50% of Black drivers carry contraband and 75% of white drivers carry contraband. Among the unlikely group, 5% carry contraband irrespective of race. And importantly, imagine in this purely hypothetical example that the police are not being discriminatory. They search everyone who is more than 10% likely to carry contraband. So they apply the same threshold to everyone, irrespective of race. What's going to happen to the hit rates for white drivers and Black drivers? Well, the police are going to search all the likely drivers, right? And they're going to end up with a hit rate of 50% for Black drivers and 75% for white drivers. So under the outcome test, that disparity in hit rates will get interpreted as discrimination. But this is misleading because by assumption, in this purely hypothetical example, the police are applying the same threshold irrespective of race. So what's happening here? Like, why are we getting this misleading conclusion from the outcome test? Oh, and I should mention, by the way, that the outcome test can also yield misleading results in the other direction where it fails to indicate discrimination, though in fact, different thresholds are being applied. So why is this happening? Well, it's happening because the statistic that the outcome test measures, the probability of carrying contraband conditional on being above the search threshold, is not the same as what we're actually seeking to measure, which is the threshold itself. These are simply different quantities. But the threshold itself is hard to measure. It's not like a simple fraction directly measurable from the data the way the hit rate is. And so the solution that has been proposed is to use a Bayesian latent variable model to infer it. So I'll describe that model to you now. The model is called a threshold test because it's trying to infer the thresholds. Basically what the model does is it proposes a stylized Bayesian model of a police stop. And the goal of this model is to estimate search thresholds that are consistent with the observed data, namely the search rates and the hit rates. And discrimination is just defined the way I discussed previously if lower search thresholds are being applied in searches of minority drivers. So how does the threshold test work? It imagines that when the officer stops a driver, they estimate the probability P that person carries contraband, and P is drawn from a risk distribution, which I've shown graphically at right. This is a probability distribution on the unit interval. So, for example, if they pull over a school bus driver, P would probably be quite low, right? Because the guy is driving kids around. It's probably pretty unlikely he's also driving around weapons or whatever. And so P would be low. If, on the other hand, they pulled over a driver who is acting woozy and drinking out of a bottle, then it's possible that's some innocuous substance, but it's also possible that it's not, right? And so P would be somewhat higher. And then if P exceeds the threshold, the officer searches the person, and if they search the person, they find contraband with probability P. So in the case of the school bus driver, he would be below the threshold. The officer would not search him, would not find contraband. In the case of the woozy acting driver, the officer would search him and would find contraband with 75% probability. The model allows the thresholds and the risk distributions to vary by race and by location, and discrimination is if the model finds lower thresholds being applied in searches of minority drivers. There are a few more mathematical details, which I'm not going to go into now, about basically how do you map from the unobserved parameters to the observed data. It turns out that we can write down the observed data, namely the search rates and the hit rates, using relatively simple forms in terms of the unobserved parameters. Specifically, the search rate is basically 1 minus the CDF, and the hit rate is the conditional mean. To complete the Bayesian specification, you put priors on the model parameters, and then you can infer the posterior over the model parameters given the prior and given the likelihood using standard MCMC inference strategies. In this case, we use Hamiltonian Monte Carlo. So at least in principle, this is simple. In practice, this model was originally parameterized using beta distributions for the risk distributions, and it turns out that this makes inference prohibitively slow because computing the requisite quantities in order to sort of map to the search rates and the hit rates is prohibitively slow. Not going to go into details about that now, but I will tell you 2 practical takeaways, which means basically because the model is so slow, you can't fit it on the entire national data set at all. You would have to fit separate models state by state. And the other is that the test can't be used by people who really need it. For example, basically non-academic practitioners who don't have access to extensive computational expertise and a ton of computational resources. So for example, journalists can't use the original version of the model, police departments who want to analyze their own data, activists, et cetera. It really limits the applicability of the test. So to deal with this problem, what we did was describe a new family of probability distributions, which we call discriminant distributions. These distributions are based on Gaussians, and an overriding lesson of my PhD was that everything is nice when you use Gaussians, and so we're able to use them to make inference much faster. Specifically, the test runs about 100 times faster. A concrete takeaway from this is that sometimes actually probability distributions do matter, and fancy math can have sort of practical implications, and this is one such setting. Okay, so with the fast threshold test, we were able to fit a national model, and I'm showing you the results here. The model does infer lower search thresholds for Black and Hispanic drivers. Basically, it infers that they're being searched on the basis of less evidence, suggesting discrimination under the threshold test as well. So to recap what I've shown you about searches, I've shown you 3 things. I've shown you that search rates are higher for minority drivers, hit rates are lower, and thresholds are lower. This is sort of a smoking gun characteristic pattern for discriminatory searches. You'll see it, for example, if you analyze stop and frisk data in New York City as well. All 3 tests here are suggesting discrimination against minorities, but the threshold test is doing so in a way which is robust to the statistical flaws of simpler tests. Just to speak briefly about the public policy impact of this work, I mentioned that one of the values of this fast threshold test was that it was easier for journalists to use. And in fact, in 2019, the Los Angeles Times was able to take our version of the test with some help from our team and use it to show that the LAPD was searching Black and Latino drivers on the basis of less evidence. And in response to this is why journalists are great. They can actually accomplish change in the real world, which I find as an academic can be challenging by writing academic papers, right? In response to this, the LAPD announced that they would dramatically cut back on random vehicle stops in an effort to reduce this racial bias. So I want to speak about how selective labels problems appear in other contexts as well. Basically, you can take the exact same mathematical playbook and apply it in other data sets where you have a binary decision and a binary outcome. So for example, in lending, the binary decision might be, does the bank give someone a loan? And the outcome might be, does the person repay it if they receive it, right? And you only observe that outcome, of course, for people who historically got the loan. So it's the same type of data sets, right? And discrimination here might look like, minority applicants are less likely to get loans, but more likely to receive them, conditional on getting them. Similarly, for medical tests, the decision might be, should the patient be tested for a disease? And the outcome might be, do they test positive for the disease? And discrimination or bias here might look like, minority patients are less likely to get tested. And if they get tested, they're more likely to test positive. So I do just want to make a quick plug here for the fact that selective labels problems are, clearly they're important, right? Because they manifest in so many contexts, and they are from a statistical standpoint, quite interesting and unsolved. They're decades old literatures in multiple fields. And in general, why are these hard? They're hard because they're unsolvable without further assumptions. The reason you need assumptions is because otherwise, the untested population can have any distribution, right? They could all test positive, they could all test negative. You just don't know. My opinion is that domain-specific solutions are probably what we want here. We might want one solution in policing and another solution in medicine because we have to make assumptions, and which assumptions are reasonable probably varies by domain. In policing, the data are often very sparse, which means that the threshold test as applied in the policing context makes relatively strict parametric assumptions, like that the risk distributions are parameterized by specific two-parameter families, and this allows them to work from relatively little data, including aggregated data. In medicine, right, as you know, we often have very rich individual level data, EHR, imaging, et cetera, implying that there may be better solutions than the threshold test. We would like to let that rich data inform our inferences. We also potentially have other sources of side constraints in medicine, ways we can constrain the untested population, and we might want to make use of that as well. And we actually have work actively along these lines being led by a talented PhD student, Siddhika, and hopefully we'll have more to say about that in a couple of months. And we'll give you a quick sneak preview, which is we took the same playbook, we applied it to COVID testing, and we did indeed find evidence of bias in COVID-19 testing, specifically different thresholds being applied by race. Basically, the pattern was, minority patients were less likely to get these tests and they had higher positivity rates, conditional on being tested. And so we sort of saw that smoke and gun pattern. And I should mention, if you have other medical problems where you're seeing this sort of pattern in the basic descriptive statistics, very, very happy to chat more about them. All right, let's talk about the second story. Let's talk about intimate partner violence. This is work being led by Divya Shanmugam at MIT. I should mention Divya is excellent. I've really enjoyed working with her. She's very much in the medical ML space. And the reason I'm telling you all this is that she'll probably be on the job market, I think, next year. And you should very much try to hire her, or maybe you should not try to hire her so we can try and hire her at Cornell. But she's very talented and she's been a pleasure to work with. Okay. So the goal of this work is to assess the relative prevalence of underreported conditions. What do I mean by all those words? So the relative prevalence is just how much more likely is a condition in one group versus another group. So here, if we're comparing Black to Asian patients and red indicates the affected patients, the relative prevalence would be 4/6 because, there are 4 Black patients affected and 6 Asian patients affected out of the same population size. So this is trivial to measure if the disease is perfectly observed. What's the problem? Diseases are often underreported, right? And if there is differential underreporting by group, here, for example, only 2 Black patients report the disease and only 1 Asian patient has the disease reported, then you'll get the wrong value of the relative prevalence if you just naively use the reported cases. Why do we care about relative prevalence at all? Well, because it is basically a way by which we can, pass more efficient and targeted health policy. An example of this is, in the 1990s, there were reports describing high relative prevalences of diabetes among Native American populations, saying they were much more likely to have type 2 diabetes. In response to this, Congress established the special diabetes program for Indians. And then over the next sort of few decades, there was a large decrease in diabetes-related complications in these populations. So this is sort of a case study for why documenting high relative prevalences can actually lead to more efficient and targeted health policy. Why do we care about underreported conditions? I suspect you already know the answer to this. It's that many important medical conditions are underreported, and furthermore, in a way which varies across groups. This is really a ubiquitous phenomenon in medicine. The condition that motivates this work is intimate partner violence, or IPV. Prior to working on this project, both Divya and I read this book called No Visible Bruises, which I do highly recommend, with the caveat that it is obviously a somewhat difficult read, but it talks in detail about sort of the invisible nature of intimate partner violence and how it's simply often unobserved. But IPV is a motivating example here, but there are many other examples of this as well. Underreporting and underdiagnosis is very, very common in medicine. And because it's so common, a frequent sort of formalism which has been applied to model it is what's called the positive unlabeled setting. Specifically, also known as PU learning. Specifically, PU learning says we observe two types of patients. We observe true positives, so people who really have the medical condition, and then we observe unlabeled patients. And those may consist both of true positives and true negatives. So you can sort of think, basically, this is widely used to model underdiagnosis, because if someone hasn't been diagnosed with the condition, like, it's possible they're really a true negative, but it's also possible they're a true positive and they just haven't been diagnosed yet. The implicit assumption here is that there are no false positives. In other words, if someone is diagnosed with IPV, they really have IPV. So you might ask, okay, how does PU learning compare to the selective label setting? Clearly, these are both sort of missing data settings, right? In the PU learning setting, it's like we don't perfectly observe patient state, right? All we observe are sort of the true positives and the unlabeled patients. So how does PU learning compare to the selective label setting? It turns out that it's harder, which should worry you, basically, because selective labels is already very hard. In the selective label setting, we observe three groups. We observe the true positives, the true negatives, and the unlabeled. So the true positives are the people who get tested, test positive. The true negatives are the people who get tested, test negative, and the unlabeled are the untested population. In contrast, in PU learning, we observe only two groups. We observe the true positives, right? And then the unlabeled. In as much as selective labels is hard and PU learning is harder, we're definitely going to have to make some assumptions to make progress here. To give you a little more intuition for why we need assumptions in the PU setting, let's say that you observe that a disease is very rarely diagnosed. Without further assumptions, you cannot tell the difference between this disease really is rare versus this disease is just underdiagnosed. Like those two things are observationally equivalent, right? So that's sort of like a basic reason for this unidentifiability. It's a basic reason you need more assumptions here. Okay, so how do people deal with this setting? They make assumptions. What's an assumption they frequently make? One frequently made assumption here is separability, that the positive and negative class are at least somewhat separable, which is to say there is a region of feature space with only true positives. To give you an example of non-separable data, I will show you this recent picture of my cats, Sigma and Mew, who, like, genuinely, I actually can't tell which cat is which. It's okay. The point being there's sort of like complete overlap in the cats. If you want to see a more sort of mathematical version of this, like basically the graph at bottom shows you an example of data that is at least somewhat separable, which is to say there is a region of that green sort of blob, right, where there is no overlap with the red blob. So why is separability useful for making progress in the PU setting? Well, if there's a region which is only true positives, like you're willing to assume there's some region of feature space where everything there is a true positive, then you can just take that region of the space, look at the fraction of examples in that region which are labeled, and then you're like, okay, that's the probability that a true positive is actually labeled as positive. Then, if you're willing to make the additional assumption that that label frequency remains constant throughout the space, then you can back out the true rate of true positives in the data. What's the problem here? Separability just doesn't seem that plausible in medical settings, right? Like it's just not that plausible, basically, that there's some magical region of feature space where everyone is a true positive, and that the label frequency in that space, in that region, would magically generalize to the rest of the space, right? Like in general, medical symptoms are often quite nonspecific. They could indicate multiple things, and so it's just not really that plausible that this would be true. So what's our contribution here? First of all, we propose relative prevalence estimation as a novel PU learning task. So Conventionally, PU learning has sort of focused on absolute prevalence estimation. In other words, can we figure out the absolute frequency of true positives? We instead focus on relative prevalence estimation. In other words, is the disease more common in Black patients versus white patients, for example? Turns out this is a somewhat easier task that you can do even if you can't estimate the absolute prevalence. We provide a set of assumptions under which you can get the relative prevalence, and we argue these are more plausible in medical settings than this sort of restrictive and implausible separability assumption. And we provide a method for doing so, and we provide a fair bit of evidence that it actually works. Without getting into the math first, let me just give you the high-level intuition for the method. Let's say you want to know about the relative prevalence of IPV, intimate partner violence, in Black patients versus white patients. But IPV is underdiagnosed, and maybe to a degree which varies across races, so you can't just take the ratio of diagnosis rates. That's the issue we've already discussed. But what you can do is you can learn which symptoms are suspicious for IPV from the few labeled cases that you have, right? You have some people you know of IPV, and you can learn, which symptoms do they tend to have. Then, if you're willing to assume that suspicious symptom model remains the same across race groups, you can back out the relative prevalence. And the rough intuition here is that the race group with the higher prevalence of suspicious symptoms has the higher prevalence of the disease as well. To make that a bit more formal, I'll introduce a little notation. So what we actually want and do not observe is Y. This is the true label for each patient. This is whether the patient really has experienced IPV. Our observed data consists of three things. This is what we actually have, right? We have S. This is the observed label. This is whether the patient is diagnosed with IPV. We have X, which are the observed features for each patient. So patient symptoms, which here we assume are ICD codes. And then G, we also have the patient's group, which we denote by G. And this is the patient's like age or race or insurance status. Basically, that's the thing we care about inferring the relative prevalence across. And the PU assumption here in terms of our notation is that basically the probability that S equals 1, given that Y equals 0, is 0. So in other words, if S is 1, S is only going to be 1 if Y is 1. There are no false positives. So our method is called PURPLE. And how does it work? PURPLE models the probability that a patient is diagnosed with a condition given their group and given their symptoms. And this is fully observed from the data, right? Because we observe S, X, and G. We assume that this decomposes as the product of two terms, or actually we make a set of assumptions under which it follows that it decomposes as the product of these terms. We assume that it is the product of the probability the patient truly has the disease given their symptoms times the probability that they are diagnosed with the disease given that they have it. We allow that second term, the group-specific reporting probability, to vary across groups to allow for underreporting. The first term, the probability that you have the disease given your symptoms, is constant across the groups. Now, notice that we can't estimate either of the terms on the right side exactly, since we only observe their product. What that means is that you could always take the first term and multiply it by 2 and take the second term and divide it by 2, right? But it turns out that even estimating Py given X up to a multiplicative constant like that is sufficient to estimate the relative prevalence, though not the absolute prevalence. So what we do basically is we first use this decomposition to estimate Py given X up to a multiplicative constant, and then we look at how it varies across groups to estimate the relative prevalence. Why is it sufficient to estimate Py given X up to a constant factor? Because basically the expression for the relative prevalence is given by this fraction. And so if you're off by a factor of 2 in estimating Py given X, it doesn't matter because it's just going to cancel out in the numerator and the denominator. So it turns out that this method only works under 3 assumptions. And I'm not going to talk in detail about these assumptions now. Well, I'm happy to talk about them in more detail during a question period, but in the interest of time, I'll just keep going for now. But I'll just briefly list that there are no false positives. That's the PU assumption. That there's random diagnosis within group. That's also very widely made in the PU learning literature. And then finally, that Py given X remains constant across groups. And that's sort of our novel assumption. How reasonable are these assumptions? My honest opinion is that they're strict and they won't hold in all cases because, yeah, assumptions never do. But I would say, First of all, it's necessary to make assumptions here because PU learning is a hard problem. I would also say that these assumptions are complementary to and probably more reasonable than standard assumptions made in PU learning, like separability, which probably doesn't hold in medical settings. And then finally, we provide assumption checks and robustness to violation of the assumptions. So does this work? Well, we show on simulated and semi-synthetic health data that purple is able to recover the relative prevalence more accurately than baselines can. The reason we use synthetic and semi-synthetic health data is because you need to know what Y is to even assess how the method performs, and on real data, you're not going to have those true labels Y. So first, we validate that it works okay on those things. I'm not going to show you those results because they're a little less interesting. I will also mention that we provide a couple of other checks to make sure that you're applying the method reliably. We provide 2 checks for whether the assumptions hold, and we also show that even if one of the assumptions is violated in a pretty reasonable way, we're still able to sort of provide a lower bound on the magnitude of health disparities. The reason lower bounds are useful is because you can say, well, I know this disease is at least twice as common in women. It might be even more than that, but you should definitely prioritize resources to them. I will just briefly show you our results on real data. Basically, we're able to recover relative prevalences, which are consistent with prior work. We apply this to the mimic sample, and it infers higher relative prevalences among unmarried patients and Medicaid recipients, which is consistent with past work. It also finds racial disparities, but they're somewhat smaller and not that consistent. The mimic sample is a bit weird for like the original mimic sample we used only consisted of patients who were ultimately hospitalized, which probably isn't quite the sample you want. We did want to study this question reliably, so we actually got a couple additional samples. We got the mimic sample that consists of all emergency department data sets. We also got the HCUP data set, which consists of 1.6 million ED visits from the state of Maryland. And in both cases, we're able to sort of reproduce these consistent results for marital status and insurance. We also have a case study applying this method to hate speech, in which we basically find that comments which mention sort of an identity group have higher likelihoods of being toxic, being hateful, than comments which do not. We also show the groups which face societal discrimination, for example, transgender people have face higher rates of inferred toxicity. Both of these things are in line with what you would expect and showcase that the method can be applied to relative prevalence estimation beyond medicine. So to summarize, here we propose relative prevalence estimation as a task in PU learning that hasn't been much focused on, but is important and can be performed even when absolute prevalence estimation can't. We give 3 assumptions under which you can do this. We provide assumption checks and robustness to a violation of the assumptions, and we show good results on synthetic, semi-synthetic, and real data. If you have other settings where you think it might be useful to apply purple, specifically basically where you care about the relative prevalence across groups and there's plausibly underdiagnosis, we'd be very happy to chat more about those. I think long COVID is an obvious case where you might want to apply this because it is underdiagnosed and you do care about relative prevalence, but there are other settings as well. All right, I'm going to move on briefly to the last story, and this is about whether we should use race in clinical algorithms. This is joint work with Anna Zink, who's a postdoc at UChicago, and Ziad Obermeyer, and it's very much a nascent paper, so your feedback is welcome. And in contrast to the previous 2 stories I told you about, this is not a story about sort of human bias. It's a story about algorithmic bias and how we can correct for it. Okay, so as you may know, there's been a very high-profile debate in the medical community about when we should use race as a predictor in clinical algorithms. And this is not just a debate which is happening in like the pages of the New England Journal of Medicine and the Lancet. It's also a debate with immediate consequences for patient care as hospitals actually change the way they're doing these calculations and senators reach out for more information. To give an example of one case where this has been debated is in the calculation of eGFR, which is an important measure of kidney function. eGFR is used, for example, to diagnose kidney disease, to determine eligibility for kidney transplants, kidney donations, etc. So it's something that really matters to sort of life or death outcomes. And historically, eGFR has often been calculated using a race correction, basically using a term for whether the patient's race is Black. And now you can see, I've shown you a screenshot from the clinical medical calculator, MD Calc, they're now making that sort of optional, and hospitals are sort of changing whether or not they use a race correction term, which will lead to sort of different results depending on whether or not you say your race is Black. So this is, happening in nephrology in the context of kidney function, but it's happening in many other domains as well. And this paper from 2020 provides a nice table giving you an overview of the many contexts in which people are actively debating this. And to be very clear, there are very good reasons this scrutiny is occurring. I'll just enumerate a couple of them for you now. The first is that many of these race corrections have been based on very sketchy empirical data, small samples, non-representative samples, undocumented samples from the 1950s. It's like, it's just sketchy stuff. There's concerns about exacerbating health disparities by using race corrections. For example, if your race correction means that Black patients are rated as lower risk by your algorithm, and that means that they're not eligible for screenings, then this might exacerbate disparities in access to screening. And then finally, of course, there is a bad history of racist beliefs in medicine about biological racial differences that just have no basis in reality. Examples of this would include, for example, radiologists believing that Black patients needed higher doses of X-rays, or, for example, this continuing widespread belief among clinicians about biological differences in how Black and white patients perceive pain. So there are very good reasons for the scrutiny of the use of race as a predictor, but the consequences of removing race remain somewhat unclear. And of course, removing predictors in clinical algorithms with life or death consequences is something you want to do carefully. Here's sort of a quote from a piece making exactly this point. So our argument here is that removing race as a predictor can have unintended consequences and indeed decrease equity in some cases. And we study a case in which this occurs when racial bias creates differential measurement error. So what do I mean by this? Racial bias can make it more likely that some race groups will have risk predictors mismeasured. And there are myriad examples of this. Our recent review paper provides a bunch of them, but of course, I've just talked to you about a bunch of them too, right? Disparities in how likely people are to be tested, whether they're diagnosed, whether they have medical records at all, right? The sort of presence of structural racism in medicine affects our measurement of just tons of critical variables throughout the medical record, right? This is a very ubiquitous phenomenon. And specifically, the one we study is family history. This is a critical risk predictor, right? If you go to the doctor for a mammogram, right, a very standard question is, do you have a family history of breast cancer, right? We often want to use family history to predict a patient's outcomes. There's also a lot of previous work suggesting that family history is more likely to be mismeasured in some race groups. For example, there's work showing that clinicians are less likely to ask non-white patients about family history. It's also known that non-white patients have higher rates of not knowing family history in some contexts. And so there's sort of multiple lines of evidence suggesting this very important risk predictor is more likely to be mismeasured. So we study this phenomenon and its implications for algorithmic risk prediction in a cohort known as the Southern Community Cohort Study. This is a large and racially diverse cohort, which was established in 2001 to study health disparities. And specifically, we study how colorectal cancer risk varies as a function of race and family history. So here what I'm plotting for you is the risk a patient has is developing colorectal cancer for white patients, broken down by family history. And I'm plotting it as a function of age because age is like a very strong predictive risk factor for cancer. And you can see for white patients, like you see exactly the result you'd expect, right? That like people with family history are a lot more likely to get colorectal cancer. It's a very strong and highly significant risk predictor. But when you look at the pattern for Black patients, it looks quite different. Now the lines are almost on top of each other. The predictive value of family history is pretty dramatically diminished. So for Black patients, family history is much less predictive. And for those of you saying, no, you can't look at like the individual significance, you should be looking at the interaction term. Yes, the race family history interaction term is highly statistically significant. So there is a differential predictive value of family history across race groups. And this is very consistent with what we would expect if there were differential mismeasurement of family history across race groups. In other words, reported family history may be less reliable for some race groups. The specific statistical name for this phenomenon is what's called regression dilution or regression attenuation, where basically if a variable on the right-hand side of the regression is mismeasured, the regression coefficient gets shrunk towards 0. And the standard statistical correction for this is, in fact, to include race in the predictor, specifically to have an interaction term between family history and between race. That is how you should correct for this differential mismeasurement. And it's not only sort of the standard statistical correction, it also results in more equitable predictions. So specifically, if you fit a risk predictor, which includes race, it increases the fraction of Black patients who are flagged as high risk, which could result in more equitable predictions if it means that Black patients are sort of more likely to receive screening. It also slightly improves AUC on all groups. That increase is not statistically significant due to the noisy predictor and the low positive rate, but at the very least, it sort of makes Black patients more likely to be eligible for screening. So concerns that like, oh, this might exacerbate racial inequity are not really occurring here. So to summarize the results, it's very much true that scrutiny of use of race in clinical algorithms is justified. But here we show that removing race can also have unintended consequences, sometimes paradoxically decreasing equity. Specifically, we illustrate this through a case study of mismeasurement of family history. I want to also note a related result that from prior work, which appeared in a study in Lancet Digital Health a couple months ago, which is that even if you remove race as a predictor, the algorithm may reconstruct it anyway through proxies. So here, these authors show that basically algorithms can predict a patient's race with sort of disturbingly high accuracy from medical images. So overall, I think the conclusion is that the solution to racial bias in clinical algorithms will not come merely from excluding race. We show that sometimes this can actually decrease equity, and that algorithms can often reconstruct race. And then other work has shown that algorithms can often reconstruct race even if it is not explicitly included as a predictor. Rather than sort of just blanket excluding race, we think we need to think carefully about the goal of clinical algorithms, which in the case we study is predicting cancer risk, and how various algorithmic design choices can advantage or disadvantage different race groups with respect to this goal. So to summarize, today I've told you 3 stories about missing data and its connections to health inequity. The first 2 stories about policing and intimate partner violence were stories about detecting human bias. And the final story was about correcting for algorithmic bias, which can arise as a consequence of differential missing data. So I really think missing data is a fascinating and important problem with profound connections to health inequity. And I'm very happy to discuss more or to answer any other questions that you have. Thank you.